There is one question every older adult should ask within the first few hours of entering a hospital. Am I officially admitted as an inpatient, or am I being kept under observation? It may sound like a minor administrative detail, but for some families, the answer has meant the difference between covered rehabilitation and a medical bill worth thousands of dollars. Let me tell you about a woman I will call Margaret. She was 76 years old when she was taken to the hospital after becoming weak and dizzy at home. She spent 3 nights in a hospital bed. Nurses checked her blood pressure, doctors ordered tests, medications were given, and meals were brought to her room. Her daughter naturally believed that Margaret had been admitted as an inpatient. When Margaret was ready to leave, her physician recommended a short stay at a skilled nursing facility so she could rebuild her strength before returning home. That was when the family learned something no one had explained clearly. Margaret had not been classified as an inpatient. She had been receiving observation services. Although she had slept in a hospital bed for 3 nights, those nights did not necessarily count as qualifying inpatient days for the rehabilitation coverage her family expected. Her daughter later asked a question I have heard from many families over the years. How could we have known? She was in the hospital. We thought that meant she had been admitted. That assumption is completely understandable, but it is also one of the reasons hospital stays can become medically and financially complicated for older adults. When someone is in pain, frightened, short of breath, confused, or waiting for test results, it is difficult to think about insurance networks, medication changes, admission classifications, discharge appeals, and financial paperwork. Most patients are focused on one thing: getting better. Yet the administrative side of a hospital stay can affect your recovery long after you leave the building. Today, I want to explain 5 common mistakes that older adults and their families make during a hospital stay. These mistakes do not happen because people are careless. They happen because the hospital environment moves quickly, the rules are complicated, and most families do not know which questions to ask until a problem has already occurred. My purpose is not to make you afraid of hospitals. Hospitals save lives every day, and doctors, nurses, pharmacists, therapists, social workers, and support staff work under enormous pressure to care for patients. My purpose is to help you become a more informed participant in your own care. When you understand what to ask, when to ask it, and what information to document, you are far less likely to be caught by surprise. The first mistake is assuming that everyone involved in your care accepts your insurance. Many patients carefully check that the hospital is covered by their health plan. They may also confirm that their surgeon or primary specialist is covered. Then they assume that every person involved in the procedure is covered as well. That is not always the case. A hospital may participate in your insurance plan while certain professionals working inside that hospital have separate billing arrangements. Depending on the situation, this may include anesthesiologists, radiologists, pathologists, laboratory specialists, emergency physicians, or surgical assistants. Imagine a 71-year-old man named Thomas who schedules a routine procedure. Before the procedure, he calls his insurance company and confirms that the hospital is covered. He also confirms that the physician performing the procedure participates in his plan. Everything appears to be in order. Several weeks later, however, Thomas receives a separate bill from a medical professional he does not remember meeting. That professional participated in his care but was not included in the same network agreement as the hospital. Thomas assumed that choosing an approved hospital meant choosing an approved medical team. That assumption is where the problem began. Federal protections may limit certain unexpected out-of-network charges, particularly in emergencies and in some situations involving care at an in-network facility. However, the exact protection can depend on the type of insurance you have, the service you received, and whether you signed a separate consent form. That is why you should avoid asking only one general question such as, "Is this hospital covered?" For a planned procedure, ask whether any physicians, specialists, laboratories, or outside medical groups may bill separately. Ask whether the anesthesiology, radiology, pathology, and laboratory services are included under your plan. Whenever possible, request this information before the day of the procedure. If someone gives you an answer by telephone, write down the date, the time, the person's name, and exactly what you were told. Whenever possible, ask for the information in writing. This does not guarantee that every billing problem will disappear, But written records can become extremely valuable if you later need to question or dispute a charge. If you receive a bill that seems incorrect, do not immediately assume that you must pay the full amount. First, request an itemized bill. It should show each service, procedure, medication, and professional charge separately. Then compare it with the explanation of benefits from your insurance plan. The explanation of benefits is not the same as a bill. It shows what was submitted, what the insurance plan allowed, what it paid, and what the provider says you may owe. If the numbers do not match, contact both the provider and the insurer and keep a written record of every conversation. The lesson is simple. Never assume that one insurance confirmation covers every person who may participate in your care. The second mistake is leaving the hospital before you have a safe and realistic plan for going home. Most patients are relieved when they hear they may be discharged. Home means familiar surroundings, better sleep, and a return to normal life. But discharge is not always as simple as putting on your clothes and getting into a car. Older adults may leave the hospital with new weakness, poor balance, unfamiliar medications, dietary restrictions, wound care instructions, or medical equipment they have never used before. A patient may be medically stable enough to leave an acute hospital bed but still be unprepared to function safely at home without additional support. Consider a 79-year-old man named Edward. He was hospitalized after a serious infection. After several days of treatment, his fever improved and his laboratory results looked better, so a discharge plan was prepared. But when Edward tried to stand, he became lightheaded. He needed assistance to walk to the bathroom, and his wife, who was 77, had back problems of her own. The couple did not feel ready, but they assumed that once discharge paperwork had been started, they had no right to question the decision. Edward went home that afternoon. The following morning, he fell while trying to reach the bathroom. This is why discharge planning must include more than test results. Before leaving, the patient and family should understand what has changed since admission, which symptoms require urgent attention, who should be contacted if a problem develops, and whether the patient can walk, use the bathroom, eat, and take medications safely. The family should know whether home health care is needed, whether physical or occupational therapy has been recommended, whether medical equipment is required, and whether the patient and caregiver understand how to use that equipment. Follow-up appointments should be clear, and transportation should already be considered. If you believe discharge is happening before it is safe, say so clearly. Do not simply say that you feel nervous. Describe the exact safety concern. You might say, "I cannot walk safely without assistance," or "My spouse is not physically able to help me get from the bed to the bathroom." You might also say, "I do not understand how to manage these new medications," or "We do not have the equipment this discharge plan requires." Specific concerns are more useful than general discomfort because they identify the actual problem. Medicare beneficiaries may have formal rights related to discharge decisions, including access to an expedited review process in qualifying situations. The procedures and deadlines can be time-sensitive, so the best time to ask about your rights is before leaving the hospital. Request a written discharge notice and ask a case manager, patient advocate, or social worker to explain the appeal instructions. Do not wait until you are already home if you believe the discharge is unsafe. Requesting a review is not an attack on your physician or nursing team. It is a request to make sure the transition is medically appropriate. The most important question is not simply, "Am I well enough to leave the hospital?" The better question is, "Do I have a safe and realistic plan for the first 48 hours after I leave?" The third mistake is failing to track medication changes during the hospital stay. For many older adults, medications become more complicated the moment they enter a hospital. A person who normally takes 4 medications may receive 8 or 10 different products while hospitalized. Some are temporary. Some replace existing medications. Some are held because of surgery, kidney function, blood pressure, bleeding risk, or interactions with another treatment. The challenge is that these changes are not always explained in a way the patient can remember. Hospitals commonly use a formulary, which is a list of medications routinely stocked and approved by that institution. If your usual medication is not available, the hospital may use another medication from the same drug class. Sometimes that substitution is clinically appropriate and causes no problem, But confusion can arise when the patient returns home. Should the replacement medication be continued? Should the original medication be restarted? Was the dose changed temporarily or permanently? Was one medicine stopped because it was no longer needed? Or was it stopped only because it conflicted with a hospital treatment? These are not minor questions. Medication errors frequently occur during transitions between home, hospital, rehabilitation facilities, and outpatient care. Older adults are especially vulnerable because they are more likely to take several medications and to receive prescriptions from more than one clinician. Imagine a 73-year-old woman named Linda. Before entering the hospital, she took medication for high blood pressure, diabetes, thyroid function, and chronic pain. During her stay, one medication was stopped, another was replaced, and a new medication was added. At discharge, Linda received several pages of instructions. She went home believing that she should take everything listed on the new paperwork in addition to the medications already stored in her kitchen. Fortunately, her daughter called the pharmacist before Linda took the first dose. They discovered that one of the hospital medications was supposed to replace, not accompany, one of her previous prescriptions. This kind of confusion can be dangerous. Before entering a hospital, maintain an updated medication list. It should include the exact medication name, the strength or dose, how often you take it, why you take it, and the name of the clinician who prescribed it. It should also include prescription drugs, over-the-counter products, vitamins, herbal products, and supplements. Do not write blood pressure pill or small white tablet. Many medications look similar, so use the exact name printed on the container. During the hospital stay, ask whether any regular medications have been stopped, replaced, or changed. If something was changed, ask whether the change is temporary. Before discharge, ask for one final medication list that clearly identifies what to continue, what to stop, what has changed, what is new, and how long each new medication should be taken. Then compare that list with the medications you already have at home. A pharmacist can be one of the most valuable members of your safety team. If anything is unclear, ask the hospital pharmacist, your community pharmacist, or the prescribing physician to review the list with you. Never restart, stop, or combine prescription medication based only on general information. Medication decisions must be based on your diagnosis, kidney and liver function, allergies, laboratory results, and complete medical history. The protective action is not to question every medication decision. It is to make sure that every change is understood before you leave. The fourth mistake is signing hospital documents without understanding their financial meaning. Admission paperwork often arrives at the worst possible moment. The patient may be in pain, a family member may be frightened, and the emergency department may be crowded. Someone places a tablet or a clipboard in front of the patient and points to several signature lines. Most people sign quickly because they assume they are simply consenting to treatment. However, admission documents may also address financial responsibility, assignment of insurance benefits, privacy practices, non-covered services, outside medical professionals, personal property, and payment obligations. Some of these documents are standard and necessary. The problem is not that paperwork exists. The problem is that patients often sign documents they have not had a reasonable opportunity to read or understand. Consider a 70-year-old woman named Carol. She arrived at the hospital with severe chest discomfort and understandably signed every form she was given. Months later, a billing dispute developed over a service her insurance plan had not fully approved. Carol had no idea what she had agreed to during admission, and she had never requested copies of the forms. Without those documents, it became more difficult to reconstruct what had happened. This is why every patient should ask for copies of all signed admission and financial forms. You do not have to read every paragraph while experiencing a medical emergency. Emergency treatment should not be delayed while someone studies paperwork. But once the situation is stable, you or a trusted family member can request the documents and review them. Pay close attention to language about financial responsibility, non-covered services, assignment of benefits, out-of-network providers, unpaid balances, and consent to treatment. If you do not understand a section, ask what financial obligation it creates. Ask whether signing affects your ability to question a bill later. Ask whether the consent is required for treatment or whether it is optional. Ask whether you can receive a copy before signing. Do not assume that crossing out a clause automatically changes the agreement. Hospital policies and contract rules vary, and a handwritten change may not be accepted. A safer approach is to request an explanation, obtain a copy, document your concern, and involve a patient advocate or a billing representative when necessary. If you are unable to sign because of your medical condition, ask who signed on your behalf and under what authority. This is also where a healthcare proxy or designated medical advocate can become extremely important. The person supporting you should not simply sit in the waiting room. That person can take notes, collect paperwork, track medication changes, and ask questions when you're too ill, tired, or confused to do so yourself. Being prepared does not mean being confrontational. A calm and precise question is often more effective than an angry accusation. The fifth mistake is confusing observation care with inpatient admission. This is one of the most misunderstood parts of hospital care for Medicare beneficiaries. A patient may remain in the hospital overnight, or even for several nights, without being classified as an inpatient. Instead, the patient may be receiving outpatient observation services. From the patient's perspective, the experience can look almost identical. You may sleep in a hospital room, receive medication through an intravenous line, undergo scans and laboratory testing, and be cared for by physicians, nurses, and therapists. But Medicare classification is not determined simply by where you sleep. It depends on the physician's order, the expected length and intensity of care, clinical criteria, documentation, and Medicare payment rules. Why does this matter? Because observation and inpatient services may be billed differently. The classification may affect deductibles, co-payments, medication charges, and eligibility for certain post-hospital benefits. One especially important issue involves Medicare coverage for skilled nursing facility care. Many families assume that 3 nights in a hospital bed automatically satisfy any hospital stay requirement connected to rehabilitation coverage. That assumption may be wrong if some or all of those nights were classified as observation rather than inpatient care. This does not mean every patient under observation has been classified incorrectly. Observation is a legitimate medical and billing category. The problem occurs when patients do not know which category applies to them. That is why you should ask early. Within the first day, ask whether you are officially admitted as an inpatient or receiving observation services. Ask when that status was ordered, whether the status has changed since you arrived, how the classification may affect your costs or rehabilitation coverage, and who can review the status with your physician if there is a concern. Do not rely on a casual statement such as, "Yes, you are staying in the hospital." That does not answer the classification question. You need to hear the precise term, inpatient or observation. Hospitals are generally required to provide qualifying Medicare patients with written notice when observation services continue beyond a specified period. If you receive such a notice, do not place it aside without reading it. Ask a case manager to explain what the notice means, how your current services are being billed, whether your physician expects the classification to change, and how the classification may affect the next stage of your care. Recent legal and policy developments have also affected appeal rights for certain Medicare patients whose status was changed from inpatient to observation. Because eligibility and procedures depend on the specific circumstances, ask the hospital's utilization review department, Medicare, or a qualified patient advocate about the rules that apply to your case. The most important lesson is this: do not wait until discharge to discover how your stay was classified. By that point, some decisions may be more difficult to review. You do not need to memorize every Medicare rule or understand every billing code. What you need is a short set of questions that you and your family can use when the situation becomes stressful. Ask whether you are officially admitted as an inpatient or receiving observation services. Ask which physicians, specialists, or outside medical groups may bill separately for your care. Ask whether any regular medications have been stopped, replaced, or changed. Ask what support you will need to function safely during the first 2 days after discharge. Ask what rights you have if you believe the discharge plan is unsafe. And ask for copies of every medical and financial document you are being asked to sign. These questions are not disrespectful. A responsible healthcare professional should understand why an older patient or family member is asking them. You may not receive every answer immediately, but asking creates awareness, and writing down the response creates a record. The worst time to organize your medical information is during an emergency. That is why every older adult should prepare a simple hospital readiness folder before it is needed. It should contain your full legal name, date of birth, insurance and Medicare information, current medication list, allergies, major medical conditions, previous surgeries, and the names and phone numbers of your physicians. It should also include the name of an emergency contact, a copy of your advance directive if you have one, and the name of your healthcare proxy or medical decision maker. Keep one paper copy in an easy-to-find location and give another copy to the person most likely to accompany you to the hospital. If you are comfortable doing so, store an updated version securely on your phone. Review the information every few months and update it whenever a medication, physician, insurance plan, or emergency contact changes. This preparation may take less than half an hour, but during an emergency, it can prevent hours of confusion. Hospitals are designed to diagnose illness, stabilize patients, perform procedures, and manage serious medical problems. They are not always designed to slow down and explain every administrative consequence to a frightened patient. That is why older adults need advocates. Sometimes that advocate is a spouse. Sometimes it is an adult child, a close friend, a social worker, or a professional patient advocate. And sometimes, when you are well enough, that advocate is you. You do not need to be difficult, and you do not need to accuse anyone of doing something wrong. You simply need to ask calm and precise questions, write down the answers, request copies, and speak up when a plan does not feel safe or clear before your next planned procedure, or before a family member faces an unexpected hospital visit. Prepare the medication list and the hospital readiness folder. Then remember the most important question in this entire discussion. Am I officially admitted as an inpatient, or am I being kept under observation? It takes only a few seconds to ask, but the answer may affect your care, your recovery, and your finances long after you leave the hospital. You are not merely a passenger in the healthcare system. You are a patient with a voice, a medical history, a family, and rights that deserve to be understood. The more prepared you are before a hospital stay, the better positioned you will be to protect your health, your finances, and your peace of mind.